Hello everyone, my name is Dr. Sonam Kivarkar and welcome to part 2 of spondyloarthritis. I hope you guys have done the pre-work. Here is the objective of this segment of spondyloarthritis. Discuss definition, clinical features, investigations and management strategies for axial spondyloarthritis or AxSpA. So if you remember our umbrella of spondyloarthritis, we have axial spondyloarthritis and peripheral. So remember the farmer's market that you went to for spondyloarthritis? In your basket, remember the main feature is inflammatory back pain, that is axial, affecting the axial skeleton, and that is why this is axial spondyloarthritis. So it is a chronic immune mediated. Remember how interleukin 17 played a big role in it? So it is chronic immune mediated inflammatory disorder. It predominantly involves the SI joints, that's the sacroiliac joint, that is the joint in between the tailbone and the pelvic bone on the right and the left side. It affects the spine. It affects the hip joints predominantly. Clinical features. So early on in the disease, you would get this typical inflammatory back, buttock or hip pain that we are going to talk about in just a minute. In more advanced disease, there is reduced spine mobility and neck mobility, and people get hunched over because of this condition. So it's a pretty debilitating condition. And the sex prevalence initially, it was thought to be a male predominant condition, but really as we are finding more and more about this condition, it is the sex prevalence almost 1:1. Axial spondyloarthritis used to be called as ankylosing spondylitis, but not anymore. So let's understand how prevalent this condition is, because you know that back pain is pretty prevalent in the United States, right? So let's take a step back and think about it. So these are 100 people. They represent the US general population, okay? Now, there was a study done called ENHANCE, and they surveyed the general US population people, okay? And what was found in that study is that 20% of the entire US population at some point had chronic back pain. And chronic back pain is back pain more than 3 months, correct? So now, if you have 100 people representing the US population, 20 of them have chronic back pain according to this study, right? However, out of those 20, 5%, or in other words, 1% of the total US population has axial spondyloarthritis, okay? So remember that. If you take all people who have chronic back pain, 5% of those will have axial spondyloarthritis. If you take the entire US population, it is 1%. Pause the slide for a bit, think about the math, and then when you're ready to go, hit next. Okay. So that means there are just so many people in the United States. So many people have chronic back pain, that is back pain more than 3 months. To find this rare condition of axial spondyloarthritis, one has to really look hard. It's kind of finding a needle in a haystack. But hey, if you have the right tools, just like the magnifying glass, right? So if you have the right tools, you can definitely find this condition called axial spondyloarthritis, refer the patient in time, treat them, and they will have a much better outcome. Okay, so there is this heap or stack of people with chronic back pain, but to find axial spondyloarthritis, you need to have the right tools. And the right tools are nothing else but history, physical examination, and some tests that we are going to talk about. So our tool number 1 is taking a good history for inflammatory back pain. So if a person has chronic back pain, right, that means if they have back, hip or buttock pain that is more than 3 months, that has 4 or more of the following characteristics, then they would be classified as having inflammatory back pain. So they need to have 4 or more out of these 5 features. So this pain is specific. Remember its clinical features. It is usually improved by stretching and exercise. It is not relieved with rest. It occurs slowly. It is progressive in nature without any accident or trauma. And people wake up from night, especially the second half of the night. They wake up, they have to twist and turn and then go back to bed. And the age of onset is less than the age of 45 years. So if they fulfill more than 4 out of the 5 criteria, then they can be classified as inflammatory back pain. Other supporting features for inflammatory back pain are morning stiffness for more than 1 to 2 hours, alternating buttock pain, and good response to NSAIDs. That means when they take ibuprofen or naproxen, they have a great response to it. So if you have the features of inflammatory back pain, then it increases your probability that this indeed could be axial spondyloarthritis. So history is super important. What are some other features of axial spondyloarthritis, right? So remember your spondyloarthritis farmers market? Yes. So there are these other features. The main thing that is going to go in your basket is basically the main thing that is going to go in your basket is inflammatory back pain. But you could have 1 or 2 of these features as well. There could be dactylitis, there could be the family history of having axial spondyloarthritis, skin psoriasis in that patient, they could have peripheral arthritis, heel enthesitis, urethritis, inflammatory bowel disease, they could have uveitis, right? So tool number 3 for recognizing axial spondyloarthritis is physical examination. So physical examination, you can sometimes see psoriasis on the skin as you see it over here. It's on the elbows, it's on the nails, on the scalp over here, and again on the elbows in this figure. You can see dactylitis, you can see oligoarthritis, you can see enthesitis, right? Any combination. Remember your spondyloarthritis farmers market and the basket, the main ingredient is inflammatory back pain, but you could have any of these features. Then to check the inflammation or pain in the SI joints, there is a special test to be done called as Faber test. So Faber is flexion, abduction, and external rotation at the hip. And when you press down, as the person is doing over here, press down on the knee, then their SI joint, their contralateral SI joint kind of hurts if they have sacroiliitis. So another test to keep in mind to detect this. And then after physical examination, we will come to this slide on how to diagnose axial spondyloarthritis. So the first step is if a person has back, hip or buttock pain for more than 3 months, then go over the features of inflammatory back pain that we studied a few slides ago. If they have 4 or more features out of 5, then ask for some other features of spondyloarthritis like psoriasis, arthritis, dactylitis, uveitis, inflammatory bowel disease, that's IBD, enthesitis or family history. If you have some supporting features and your suspicion is high, then go ahead and order not a lumbar spine x-ray, but a SI joint or a sacroiliac joint x-ray. And this is what you will see, right? So you will see some inflammation and erosions and sclerosis going on in the SI joint. So for comparison, this is the normal SI joint. See how clean the margins are, how clear the margins are, as opposed to this blurry margins that are seen right here with some erosions over here. So that's how you diagnose axial spondyloarthritis. If you suspect it, order a sacroiliac joint X-ray film, and if it shows some changes, then you would classify this as radiographic axial spondyloarthritis. Radiographic because it's seen on the X-rays. Now, in later stages of axial spondyloarthritis, you would start getting even the spine involved. So initially it's only the SI joints involved, and now the spine is also involved, right? So over here you see something known as syndesmophytes. So basically what you see over here is this is the AP view. So you see on this X-ray, you see this is a vertebra right here, and this is a vertebra right here, okay? So in between these vertebra, there is a disc space, right? And typically, the disc is surrounded by a connective tissue called as annulus, okay? That's a ring. Annulus is a ring. In late axial spondyloarthritis, you get calcification of the borders of the annulus, giving these syndesmophytes. That is, you see these bridging syndesmophytes, which you shouldn't see any calcium technically, right? As axial spondyloarthritis progresses, now it's not only the syndesmophytes, but you get ossification of the anterior longitudinal ligament and the facet joints, and then you get a stiff bamboo spine, and then the patient is stooped over, and their neck is deformed, their spine is deformed, and it's very, very difficult to continue to do their work and do daily living activities. So it's very important to detect axial spondyloarthritis in the early stages when we can do something about it and treat it with medications. Now let's say a person has back, hip or buttock pain for more than 3 months, and you suspect inflammatory back pain, you take some more history, and you think, okay, this is spondyloarthritis, but to your surprise, the X-ray of the sacroiliac joint is negative. What do you do next? You look for other evidence, okay? So at this point, you might want to order a HLA-B27 gene test and a CRP, that is an inflammatory marker, okay? So that's what you order, and just concentrate on these 3 things, right? Because now the X-ray did not show you much, so you have to look for some other clues. So now if you have any combination of 4 features, okay, you either have inflammatory back pain, you have skin psoriasis in the person, and they have a family history of Crohn's disease, and say they are HLA-B27 positive, okay? So if they have these 4 features, so if you have 4 or more features, then you can directly diagnose them as non-radiographic axial spondyloarthritis. It's called non-radiographic because there are no changes seen on the X-rays, correct? But say they just have less than 4 features, right? Then what would you do? You still suspect it, right? So order a MRI of the sacroiliac joints. If the MRI is positive, then diagnose them as non-radiographic axial spondyloarthritis. If it is negative, consider some other diagnoses. So this is what you would see on MRI when there is inflammation around the sacroiliac joint. So that white part over here is all inflammation. So remember how we ordered the HLA-B27 in the working algorithm? So I want you to understand, what is HLA-B27. So HLA-B27 is nothing but a gene test, okay? About 90% of people with axial spondyloarthritis have this gene test positive, okay? So majority have this gene test positive. Now, in the US, the prevalence of this HLA-B27 is 6%, right? So you have 6 people out of 100 who have this gene test positive. But only 5 to 10% of those people who have HLA-B27 positive actually have axial spondyloarthritis. So, just to be clear, not all people who have the gene positive will have the disease. But if you look from another angle, 90% of people who have axial spondyloarthritis have HLA-B27 positivity. Okay, so keep that in mind. So even if the gene test is positive, it should be, take it with a grain of salt, right? So the take-home point is order this HLA-B27 test only and only if you suspect that this person has axial spondyloarthritis. Don't use this as just a screening test for all people who have back pain. Otherwise, you will spiral down a rabbit hole. Okay, so this is again to put things into perspective. So remember, the big umbrella is spondyloarthritis. You have axial spondyloarthritis, mainly affecting the SI joint, the back, and the hips, right? And then you have the peripheral spondyloarthritis, in which you have psoriatic arthritis, IBD associated arthritis, and reactive arthritis. Further, axial spondyloarthritis can be broken down into 2 parts, right? Radiographic, that means there are changes on the X-ray, and then the other is non-radiographic, right? When you can see changes on the MRI. I think this is a great summary slide for us to go over. So let's first concentrate on this panel. So there are about 6% in the US population, 6% of people, that's a big number, right? That's who have this gene markers present for HLA-B27. But they don't have any clinical manifestations, right? So they have the genetic markers, but no clinical predisposition, right? Then remember, back pain is very, very common in the general population, right? So back pain could be mechanical, like you pulled a muscle, right? That's mechanical back pain. Or after an injury or accident, or it could be due to osteoarthritis and so many different conditions, right? But a branch of this back pain tree is inflammatory back pain. So it is a type of back pain, and we spoke about that early on, right? So inflammatory back pain, a lot of people could have inflammatory back pain, right? That doesn't mean each and every one of them will have axial spondyloarthritis. Only a subset of patients with inflammatory back pain go on to develop axial spondyloarthritis. They initially start as non-radiographic axial spondyloarthritis, means changes can only be seen on the MRI, but some people progress, and they progress to have damage even seen on simple radiographs, and then it is called as radiographic axial spondyloarthritis. Okay, some people go on to be more advanced, and they have those syndesmophytes and a bamboo spine. So basically, this is the concept of axial spondyloarthritis. Treatment of axial spondyloarthritis is pretty straightforward. So the first line is stretching, physical activity, physical therapy, and trying NSAIDs. If that fails, remember, no use of methotrexate or sulfasalazine. You have to go with big guns like biologic agents like Humira, right? Like Remicade. So that was it for me for axial spondyloarthritis. It's a very important lecture. I would say the high yield topic for your exams will be segment 2. So go over it once again. Please post questions on our WhatsApp group and I'll be happy to answer them for you. Thank you.